Welcome everyone. So the first video we'll be looking at today is called the intraosseous access video. So this essentially is a procedure that we do if we cannot find an IV line or an intravenous line. Now, in emergency cases, especially in cases whereby there's low cardiac output or low blood perforation to the peripheries, so your hands, your arms, your legs, it's just central, and we can't even also find a central line, so in your arterial line, we have to resort to other means, and the best way that medicine is found is via the intraosseous access. So that's literally putting a needle through your bone in order to access the bone marrow. So that's what I'll be showing you, but in this case it will be a pediatric patient, so it'll be a baby, right? We typically do it in babies because their bones are much more brittle, so they're much more easier. They're still new and fresh, so we're able to get easier access. But with an adult patient, it just requires more force. It's still able to be done. So I'll be taking you through a step-by-step procedure with a doll model. Hope you guys enjoy. Thank you. The thing we do is prep our equipment, right? We need to make sure that all the equipment we need is right next to us so we don't have to move around a lot. Then we prep our patient, maybe by putting a towel or a small pillow underneath the limb that you know you'll be working with. I'll be working with the lower limb. So there's various sites of access that we can use in peds and in adults. In this particular case, I'm using the one that's next to the tibial tuberosity. So I flex the knee, I palpate the tibial tuberosity, and I go 1 centimeter beneath it, right? In private settings, there is a drill that's available for this. However, in rural settings, we have to use a very hard cannula. Right now I was aspirating for any bone marrow contents, or you could use normal saline and flush and look if there's any edema of the leg or affected limb, right? To know that either you're in or you're not in. Then I'd connect a three-way valve. A three-way valve is very important in this procedure because it allows you to manipulate your line. You could give medication to your IV bag as opposed to directly the patient, or you can stop any fluids running in at any time. It's very important to have a three-way valve. In this emergency case, it restricts and allows various things to happen just in case there's an accident. The most important part of this procedure is having a very stable IO access line, right? We don't want this to move or to bend. It could cause further damage to the patient because at the end of the day, we're breaking bone. So the best way to secure this is wrapping gauze around the actual cannula itself, not around the limb of the patient. Wrapping around the limb could really cause future complications such as compartment syndrome. We need to make sure that our patient is warm and comfortable, the line is stable, it's not too mobile, and it doesn't remain for a long period of time. IO lines aren't supposed to remain for longer than 12 hours. So as soon as we're able to gain IV access, it is important to discontinue your IO access. This next video is going to be looking at a respiratory examination. Now, respiratory examination is done routinely as a general exam, but also it's usually done when we need to look at a patient that has respiratory symptoms. So if you have a cough, or if you feel like your voice is a bit hoarse, or if you just have an overall infection, we typically do a respiratory exam. So this is a systemic exam. We're looking specifically at the respiratory system, so focusing on the chest mainly, but we also will include a general exam that hint on a respiratory exam, as I will speak about stuff that pertain to cyanosis, so that's bluish discoloration of the mouth and the fingertips, and the way the patient is positioned. So we'll be looking at 4 subtopics: inspection, palpation, percussion, and auscultation. So we'll be looking, feeling, tapping, and also listening to the chest of the patient. Hope you guys enjoy. Thank you. First thing we do in any exam is acquire consent. So you'd have to speak with your patient, inform them of your intentions with the exam, and ask them if they approve and whether they understand everything you spoke to them, right? Once that is done, then you'd have to expose the patient's area in which you wish to examine. In this case, we'll be examining the chest mainly, but we'll also be looking at other aspects of a general examination. So in inspection, in a respiratory case, we look at, for example, cyanosis, which is bluish discoloration of the fingers and mouth. We'll also be looking at respiratory distress. We'll also be looking at the symmetry of the chest. We also look at the fingertips, if they are clubbing, so if they're swollen. We'll also be looking at the way that their chest is shaped, right? Very indicative of certain conditions that will make us note that the patient has some level of infection or pre-existing respiratory condition. During inspection, it's also important to note the rate at which the patient is breathing, whether it's high, whether it's low. It's also important to note if they're using any type of additives or equipment, like an asthma pump, or if they're currently on oxygen therapy. The next section of the examination is called palpation. So this requires us to actually feel the patient's chest. The first mechanism is chest expansion. So we're trying to see how well the patient is able to breathe in and breathe out in a symmetrical fashion. If one side is irregular than the other, it notes a certain condition. Perhaps the lung is not expanding as well as it should be, or perhaps there is too much density in that particular lung cavity. Next technique is assessing for tactile fermeters. So tactile fermeters is essentially the frequency of vibrations that can run across the lungs upon the patient speaking. So you palpate with the side of your hand and ask the patient to make a statement like 66 or 99, and you feel the vibrations. If they're too high or if they're absent or non-existent, it's indicative of certain conditions. The next technique is called tracheal deviation detection. So we use two of our index fingers and place them at the ends of the clavicle, and we use our middle finger to stroke the trachea. This is to show us the position of the trachea, whether it's symmetrical to the chest cavity or if it's to the left or to the right. Now we move to the third section of our examination called percussion. Now we use a certain hand technique whereby we strike our non-dominant middle finger with our dominant middle finger in order to elicit a sound on the lungs, right? This is going to be able to tell us whether the lung is quite dense because of an infection or if it's quite hollow because of maybe damage to the lungs or even a collapsed lung. We do this in each intercostal space, and we do it segmentally. So one side across the other, we do it anteriorly, laterally, and posteriorly. The next and final stage is auscultation. So this is us using our stethoscope to listen to the lungs. We auscultate in the same regions that we percussed, right? And there are various lung sounds which I'll let you listen to in a moment.